Thank you very much for setting the scene. My name is Sabine Vogler, and I will now give the presentation jointly with Nora. Maybe a few words about myself, my conflict of interest. I am from the Austrian National Public Health Institute, which is owned by the Ministry of Health. And I would also like to make the disclaimer, I'm director of a WHO Collaborating Center for Pharmaceutical Pricing and Reimbursement Information, meaning that I can present myself as center, use the logo, but it's a nomination towards the department that I lead. I'm not staff, and I'm not talking on behalf of WHO. And maybe from the background, I am an economist and a policy person. So what will I be talking about in the next 10 minutes? I would rather set the scene, so to provide you with the rationale for price transparency and net price transparency, also show you some data from studies, how far have we come in the WHO European region with transparency, and then present really very briefly some initiatives both in policy making and particularly in research on moving forward price transparency and with some arguments why price transparency, to repeat it, is important and which roles hospitals can play. And I think that will lead very well over to what Nora will be saying. So in 2019, there was at the World Health Assembly a resolution, the so-called Transparency Resolution, and it had different requests, and among others, there were several requests by the member states. I also have to say that this resolution was adopted by nearly all members of the WHO, apart from 3 countries that abstained, and the member states committed themselves to work on appropriate measures to share information on net prices of health products, so both pharmaceuticals as well as medical devices. And net prices are defined in that resolution as the prices that are reached, and I will come to that and explain later, during confidential negotiations. The rationale for that is both. Once, on the accountability aspect, so because it's public money, it's taxpayers' money, and so the public should know what is spent on that. But also on improving access to medicines and in a fair and equitable way. And I will explain that later, but this helps if you move forward with net price transparency, that overspending in this international price comparison is stopped, that not wrong signals about fake prices are sent to other countries, and eventually it strengthens the purchasing power. In that resolution, some other areas were covered as well. Quite some public attention was also to support the dissemination of results and costs from clinical trials. What's the argument behind there? I mean, results, it's clear, it's a moral and ethical obligation, and also to protect patients to redo trials just because it was not published. And costs, well, we come back again to the area of pricing, because the high R&D costs are used by the private sector to argue high prices. But we do not know, there are several numbers out there, what is the R&D investment? And we also know that there is a high public funding aspect in that. There was other aspects as well where countries committed, and they all help to improve policy making and to know better about it. As part of a WHO European region process, there was then a survey done how high the transparency is actually implemented in the European region. And you see here, for the list prices, quite high. Some countries in Central Asia that are part of the European region do not have it, but when it comes to the net prices, we have an issue. And what do I mean by the list prices and the net prices? So the list prices are those prices that policymakers set based on different criteria, value, HDA, but often also one criterion is the prices in the other countries, the list prices. And then a benchmark price is set. But that's not affordable. So what happens? You're all well about. Then a price is negotiated, a discount that has to be kept confidential. It's negotiated at national levels as well as by procurers, hospitals, for instance. And there is this agreement, the net price, the actual price has to be kept confidential and published, because there's an obligation in the EU to publish prices, are the higher list prices. And the other countries, again, the story starts again, apply the higher list prices. What can be done and what has been done to improve net price transparency, as also in countries committed to do so in the WHO transparency resolution? Well, that's maybe not much, but at least to flag in the price lists and databases. Be aware what you see here, that's not reality. So just flagging there is a discount, but not talking about the amount of it. Austria does it, and the European Payers Database, Europid, does it as well. Italy, following the World Health Assembly 2019, tried to change its pricing system and include it as a requirement to the pharmaceutical companies when they submit the price application to provide the price data in the other countries, the net price data. In reality, it did not work out that well, but it was a good and I would say also really important initiative. The other parts are not always about net prices. There are several cross-country collaborations, but this does not mean that the net prices are shared. For instance, Benelux does not share the net prices, but at least sharing knowledge, the processes. And there is the possibility also to create a clearinghouse that net prices are shared with a third party, trusted third party, and then they are published or published among that group, up to how it's then done, in an anonymized way. And this was also done in policy making in Austria. It was started, the project was then discontinued, and for medical devices, totally different field, there was also an initiative where Dutch hospitals committed to and engaged in. Research. Well, our institute had a project where we collected about 15 years ago net prices, and I think it was very useful, and it was the hospitals, 25 hospitals that provided data from 5 countries, and probably you cannot see it in detail, but what was then quite clear, the amount of discounts, it totally varied, whether it was a product that would be then used in the outpatient sector or a monopoly product. And there were other surveys, for instance, one which you see here from health policy, where with kind of a clearinghouse, it was also redone. And research finding that I would like to share with you, it was not directly on the net prices, but on the impact of these managed entry agreements, confidential agreements. And in a difference analysis, it was shown quite well that countries that did not use them had lower prices. Clearly, the discount is, of course, factored in the list prices. And what I would really like to stress, that it is a controversial discussion about net prices, but there are often many claims made. Also the claim, well, these confidential discounts are needed to improve access to medicines. That's a claim for which no empirical evidence is there. You see it here from a policy brief for the European Observatory on Health Systems and Health Policies, where we did also a literature review. I also have to say, to showcase empirically that it helps, there's also not much literature out there because there's so much confidentiality, and that's the reason why it's so important to do research on it. That's a study many of you are well aware by Wim and other members from OECI. Some years, meanwhile, ago, Noah will also present it probably afterwards. What I find interesting in that study is I calculated the difference between list prices and the net prices. And what was seen in that study was that countries that had a large market like Spain and Italy, they were more successful to negotiate higher discounts, and countries in Eastern Europe less. Could be an interesting indication. So, to sum up, why is there a need for price transparency, in particular net price transparency? There's the argument of accountability and good governance, but also there are some indications, and we have to support these indications by strong empirical research, that it helps to improve access to affordable and equitable medicines. And my understanding is that hospitals can really play a major role as contributors to price transparency. And I now hand over to Noah, who will then follow up and explain details. Thank you.
That was my cue. I feel honored to continue the presentation of Dr. Vogler on transparency by showcasing some of our research we do in the research group of Professor Van Harten and Professor Rittel at the Netherlands Cancer Institute in the umbrella of and funding of the European Fair Pricing Network. Because of all the complexity that Sabine was talking about, we see that price negotiations are happening in countries on various levels. They are happening on national level, regional level, they can happen on insurer level, and also on hospital level. We have two ongoing research projects on this. In the first research project we call Transparency 1, we focus really on this national level, on all the managed entry agreements which are given and conducted and agreed to on a national level, sometimes regional level. And then we have one project really diving into the role of hospitals. I'm focusing on the latter, but I'm starting with the first to show that we have really a full understanding, or want to gain a full understanding of transparency and find pieces of the puzzle. So the objective of this first project is to improve transparency regarding managed entry agreements by investigating and comparing non-confidential elements across European countries. So what we see is that many countries, because of public accountability, do publish actually aggregated price information, and we are collecting this data. So what we do is that we, per country, we really dive into the flow chart and the negotiation processing, how governments or other authorities do conduct or do come to these agreements on national level. Then we look into how many managed entry agreements are available per country. And yeah, here it's really small. I cannot dive into the results now, but you see, for example, that France has way more, that France is the yellow line, has way more managed entry agreements than many other countries. And then what we do, we compare the publicly available information, because on an aggregated level, we don't have to oblige on confidential clauses. So we can aggregate information and publish much more than we are doing at the moment. So for example, here you see in small the Dutch and the French system. You see that the French in the light blue has way more in terms of money, way more savings or price reductions because of their negotiations than the Dutch system. But in terms of percentage, the Dutch have a higher percentage of discount. So it's 46% in the Netherlands and 23% in France. So this just is supposed to give you a flavor. We do this for 15 countries on how we can collect some more information than that what is known at the moment. But what I'm really looking forward to is to show you some of our preliminary results of our second project, and also invite you to still join. So, because this is an ongoing project where we are continuing our data inclusion at the moment. So I don't think I have to go into the rationale why this is important. Dr. Vogler did this already quite convincing. But the objective of this project is a continuation of this old actual price study from the OECI group. So we are going to collect average actual prices of cancer medicines. And we have a softer objective where we also want to look into price reduction strategies, dosage reduction to cost containment, etc. You might understand or be aware that collecting price data is really sensitive. So we have invested quite some time into our methodology, into how to stimulate participation, invite people to join, to be co-authors. We have had, of course, ethical approval, but also internal and external legal consulting. We have this approach which we name the power of the many, which is really around anonymity and aggregation. So we never show price data of individual hospitals. We only aggregate our information. And we have a really adaptive methodology. And what I mean by that is this, what we call aggregation pathway. So ideally, in this project, we want to collect 3 price points per country. And then we are able to show the average price of the product, for example, pembrolizumab. But if this is not possible, we have selected always multiple products, at least 2, which match on ATC4 level. So we can then, for example, for the PD-1, PD-L1 inhibitor, we have nivolumab, pembrolizumab, and we can show the average discounts that are given for a specific country. And then there's also this third option, because some of us have maybe only national prices, or it's not so easy to show these individual prices, so we can also group information on a country level. So why can we not, for example, publish the average price of the Scandinavian countries or the Eastern European countries? And then, really important, there's also this option that we do not publish data. So if we are not successful in publishing sufficient data for your country, we will not publish this data. And we only use price data from 2022, which was an advice of our legal counseling. It's older, still relevant data, but less sensitive. So here you see the selected medicines where we are collecting information on. We have collected 15 medicines, which match always 2 medicines on the ATC4 level. And we did not only look at this ATC4 level, we also looked at the patent expiration date. So what you might be known, that there is this vuvuzela of competition, that you start in a monopoly situation, go to the oligopoly situation, and then ideally at some point after patent expiration, you have competition and prices go naturally down. So we have chosen medicines in all of these situations. And now it's an ongoing study, but I want to give you a sneak peek of our results. First of all, I start with the less exciting, the publicly available data. Well, it's what Sabine talked about, list prices. We have chosen here average prices, average trade prices, and we have purchased this data from IQVIA. And you see here on the x-axis the different medicines, products, and then on the y-axis the relative trade prices in percentage to each other. And for example, if you take this first one, abemaciclib, you see that there's a huge difference from the lowest price to the highest price. It's 125% difference, which is for this package more than 3,000 euros. If I now dive into this one medicine, still on this public data, we did match these price points with the GDP per capita of a country. So you see the GDP on the x-axis and the price on the y-axis. And what's pretty interesting is that we have some countries which have a similar wealth, but their prices are really different. We could ask, why is this? We also have some countries which have quite high public prices, but their GDP per capita is lower than some of the other countries. If I look into one more, we can do this for all, but I don't have time for it. But you see, I picked one medicine where the prices are not that different, right? They are closer together. But if we look at this, we could make an argument that it's maybe not really fair that countries of Czech Republic, Bulgaria, and Hungary pay the same or even higher prices than Sweden, Norway, Germany, and the Netherlands. But yeah, what about real prices, actual prices, net prices? These are fake prices. So ideally, we would like to do this with the actual prices. So what we are doing is we are collecting data, and this is our inclusion status. To remind you, our goal is to have 3 hospital prices per country. So we are really happy to say that we will be able to publish data on a product level for the Netherlands, for Germany, and we are working really hard on France, Italy, Hungary, and Portugal. But yeah, this is also an invitation to still join us. Data inclusion is still open, and you can be part of this project and become also co-author if this is of interest for you. I'm only now showing you some average results because I don't want to influence you if you participate in the end. But what we see already with this inclusion of 12 hospitals, there was an average discount of 28%. And we see a really big difference between patented medicines and non-patented medicines. I can dive into this even closer and really analyze the competitive situation where medicine is into. And we see nicely that with more competition, the discounts given by the companies are higher. And even more, we can do this and dive into the different ATC4 classes and look into the difference of discounts given there and these products. So come and join us. It's an invitation. I think it's an exciting study, and the amount of work is actually quite manageable. This was really a priority for us. So usually we have an introductory meeting where we talk to a hospital pharmacist or financial department in a hospital. Then the preparation of these activities takes about 90 minutes, 90 to 120 minutes. And then we have an interview scheduled where data is anonymously submitted through an online portal, and it's only orally, so there's no paper trace of data submission. And yeah, I said it a couple of times, but co-authorship and a more active participation is also possible. And now I want to say thank you and wake you a little bit up after lunch. I would like to ask you to take your mobile phones and scan this code. You can also go to menti.com and enter this code. And we have some questions prepared for you, which will hopefully soon come to the screen. Yeah, to also get your perspective.
Already started, and you started to provide the answers. probably 40 people have already voted or are in.
Oh.
The code, yeah. Then you would need to click back. Here it is.
Yeah.
And we have already seen the answers to the first one. The idea is really to break the ice. So from what I've seen, high prices of anti-cancer medicines are challenging for your hospital. There was quite a yes, but I think there were a few no's and some undecided, but overall quite high numbers. Yeah, if we maybe go immediately to the second questions. So it's about if your hospital successfully negotiates with the pharma companies to purchase cancer medicines at a price that is more affordable. I think the vote is still ongoing. You have technical problems? Mm-hmm. I mean, if the idea was with the poll that you can do it in an anonymous way, because otherwise we can always do it in an alternative way with asking people to give hands up, but it might be that some would not like to share it. The QR code should be seen once again. Yeah. Okay, if it doesn't work, I would say just think about it, maybe no hands up because unless someone wants. And yeah, then I also stop and do not present the last question because in the sense of time, the other speakers also need time. I would maybe just allow one or two questions or comments. So if you want to comment, it's fine. But in that case, please limit the comment to a rather short comment. But also, Nora and I are gladly available for any question, clarification.
Who would like to pose a question or remark?
I don't see anyone, so then we give some time to the next presenters, and thanks a lot for the attention.
Yes, thank you very much. And just also to give another clue, our impression is that most hospitals think very favorable of their own performance in terms of price negotiations. And when you look at it, we discussed it yesterday, it is just like driving. Everyone thinks he drives better than the others. But that cannot be the case mathematically. So we hope for involvement in this project, and you can turn to Nora later on, and we will be happy to discuss the matter with you.